We are live, Prof, so you are more than welcome to take us away.
All right, thank you very much. Good morning, everybody, and welcome to day 2 of the Public Economics Winter School. I'm delighted to be taking the role of moderator of this panel on saving lives and livelihoods. I think the topic is enormously important because if COVID has taught us one thing, it is that we live in a world of uncertainty, both respect to risk of infection and its consequences, but also to uncertainties in people's lives. And that includes people who are most vulnerable. And that vulnerability and the inequality of the effect of COVID and the impact of interventions to prevent its transmission are felt in every country in the world. In today's panel, we're going to start with Dr. Yogan Pillay. Yogan was Deputy Director General for Health Programs in the National Department of Health for 12 years, and he's now the Director of the Clinton Health Access Initiative. As you'll see from this, if you quickly scan the slide, he was trained in the United States at Johns Hopkins, and he has recently received several awards, including the Karel Stiblo Medal, recognizing his role in fighting tuberculosis. The second speaker will be Ronelle Berger, who is a professor in economics at Stellenbosch University. Her work is in the fields of social justice, vulnerability and exclusion in African countries, and in that respect, her interests and mine coincide in many respects. She has consulted with national and provincial governments and with various multilateral donors, and that includes both the UNICEF and the World Bank. And she has affiliations in Canada and the UK and with the Pan-African Scientific Research Council. The third speaker is Professor Musa Moshabela, who is Deputy Vice-Chancellor of Research and Innovation at the University of KwaZulu-Natal and was previously the Dean of the School of Nursing and Public Health in Health Sciences at UKZN. He is a medical practitioner with a background in demography and health and research in public health, including health systems and policy, but also with an established interest in traditional medical practice and care. The final speaker will be Mark Blecker, who is Chief Director of the Health and Social Development in the Public Finance Division of National Treasury. And so he, of all of us, brings to the table a discussion around social insurance, social protection, and social modelling. He was co-chair of the UN AIDS Economic Reference Group, and AIDS, clearly, for those of us in South Africa, provided a rehearsal for many of the issues that we face today with COVID. Mark works with various multilateral organisations, including WHO, Gavi, and the Global Fund, and he's currently involved in a multi-country study on universal health coverage. My name, as was introduced, is Lenora Anderson. I'm Distinguished Professor of Medical Anthropology and Public Health at the University of the Witwatersrand. And it is, as I said, my pleasure to moderate this panel. I have asked each speaker to speak for 15 minutes, and we will be starting with Yogan Pillay, which is why I've brought you back to this. If you wish, please put any questions you have in the chat box and we'll pick them up later. But the plan will be that I will ask each person in turn to speak for 15 minutes without pause for questioning, and then we'll have 30 minutes of discussion when you will have the space to be asking questions and commenting on these presentations. Yogan, thank you.
Thank you, Prof. Manderson, and good morning, everyone, and hello to my fellow panelists as well. I'm going to share my presentation quickly. So My presentation is focusing on making decisions under considerable uncertainty and with only the early evidence. And I will be speaking really about the first period of our COVID reaction, and that is from January 2020 through to around May, with some updates on the data. So I think it's a reminder that this virus is a new virus and was only identified when a cluster of cases of pneumonia were discovered in Wuhan province in China on the 31st of December 2019. The WHO very quickly established an incident management team, and by the 10th of January produced some technical guidance on the detection, testing, and management of this disease. It was only on the 14th of January 2020 that the WHO announced very limited human-to-human transmission and confirmed human-to-human transmission on the 22nd. So almost 3 weeks after the first cases were identified, we discovered that human-to-human transmission was happening. And on the 30th, the WHO declared this as a public health emergency of international concern and called it the novel coronavirus 2019 nCoV, and released on the 3rd of February a strategic preparedness and response plan. And this plan was basically developed out of previous pandemics, the SARS pandemic, MERS, as well as Ebola, because we didn't know too much about this new virus. And on the 11th of February, announced that the disease caused by novel could be called COVID-19. So it was only in February that we had a name for this virus. The first case in Africa was only reported on the 14th of February in Egypt. And we know that South Africans, the first South Africans that were infected, were working on the Princess Diamond cruise ship outside of one of the ports of Japan. And this was identified on the 25th of February. And it was only on the 18th of March that the WHO launched the Solidarity Trial, an international clinical trial to generate data from around the world to find the most effective treatments for COVID-19. So you can see that this happened almost 2.5 months after the first cases were identified. Now, moving on to South Africa's response, South Africa responded very early to the early signs of a new virus. And on the 31st of January, South Africa activated our Emergency Operations Center to coordinate the response to COVID, one day after the public health emergency of international concern was announced by the WHO. And on the 2nd of March, the first draft COVID-19 pandemic preparedness plan was circulated. I was, during that time, the Deputy Director General responsible for health programs, including communicable diseases, and this was part of my portfolio. On the 17th of February, the NICD reported testing 46 individuals, but none of those individuals were positive. Our first case was identified, as is well known, on the 5th of March. I think we should also remember that on the 13th of March, 128 South Africans were repatriated from China amid a lot of concerns about importation from China. The good news is that there were no importations in that cohort from China. On the 17th of March, a number of us in the department had a day-long meeting with the minister where we identified 16 key issues with instructions from the minister on what to do. And interestingly, when I look back, these are the same key issues we are dealing with today. So I think with the leadership of the former Minister of Health, I think we were spot on in the kinds of things we were planning to react to and the kinds of things that we did indeed react to for the first 5 months and beyond. By the 18th of March, noting that the first case was diagnosed in South Africa on the 5th, we had 150 cases. And by then we had to figure out what was going on and how we would respond as a country to this pandemic. There were a number of initiatives to do modeling to try and figure this out in terms of what would happen and predict the trajectory of the virus going forward. And on the 23rd of March, I convened, while I was in the department, the first meeting of the various modeling consortia or individuals involved in modeling to kind of look at whether or not we had sufficient data to model out the virus. And what was fairly clear was the high degree of uncertainty amongst the modelers, largely as a consequence of lack of data. By the end of March, we had over 1,000 cases. So if you look at this slide, you will see that we had to first figure out how to get routine reporting up to date. And between the 28th and 29th of March, the minister instructed a few of us in the department to meet with the NHLS and the NICD to find ways of stabilizing the data so we could report on the data almost in real time, one day behind, to be honest, to the country. And as you know, this reporting has continued throughout the period that we've been responding to the virus. By the 6th of April, the modelers had been able to put together a model that would be able to show us what additional funding we needed to respond to the model. And this was the first early presentation to National Treasury. And I think Mark will speak much more about this. But we focused on procurement, production of, and at the same, on that same day, between the Ministers of Health and at that time DTI, there was a meeting about procurement, production of PPEs, ventilators, and test kits. So fairly early on, South Africa wanted to figure out whether there could be local manufacture of this, even though we didn't know what the trajectory of the disease was going to be or the requirements for these particular products. By the end of April, we had almost 5,000 cases and 88 deaths. And 2 weeks later, 14,000 cases and 260 deaths. And what I'm showing here is the rapid escalation in both cases and deaths. In order to focus at community level, on the 30th of March, we mobilized over 5,000 community health workers to do community screening. And that number exploded over a fairly long period of time until we ran out of test kits because of significant challenges getting test kits into the country because of lockdowns throughout the world. So even though we wanted to test more people, there were constraints with respect to the number of test kits we had. Moving forward then, over about 6,000 cases by the 1st of May, and by the end of May, 32,000 cases and almost 700 deaths. So what's happened since then? This slide basically shows by province how cases accumulated over time, and you could see that at least in the first 5 months, by the end of May, the pandemic was being led by the Western Cape, and I think this is now well known. So we had a lot of experience from colleagues in the Western Cape on how to deal with it. You will note, though, that when we had the first severe lockdown, the number of cases were still low, and South Africa then got a lot of praise for acting early. But as the cases started to rise, you will see that we reduced from level 5 to level 4 at the time when cases were rising. So you might argue that the lockdown, which was eased because of economic and other considerations, did not help the escalation of cases. Moving forward, in terms of deaths, you can see that the deaths, as you know, parallels the cases. And I think what we should say, and I'm sure Slim said this, Professor Karim said this previously, that we are 10 to 14 days behind the virus because it takes 10 to 14 days to incubate before you get symptoms for those that are symptomatic. And then a further few days before people get ill enough to require hospitalization, and a further few days before people die. So deaths lag, the transmission by quite a long period. And we therefore find many more deaths even as cases start to fall. An overview of daily cases with the events. This slide basically shows all of the interventions that were put in place at different points in time across the 3 waves. And as you can see, the second wave was significantly higher, peaked significantly higher, and was much more sharp than the first wave. And the third wave has peaked slightly higher, and we still don't know where it will end, than the second wave. But what we are finding is that there's starting to be a bit of a plateau in the third wave relative to the second wave. And again, this shows what I think we've now learning, that this virus is really unpredictable even after 18 months into the pandemic. We're still learning a lot about the virus, and it's still uncertain. Because what we do know is that we've had the spike in the third wave, a result of the Delta virus. So as the virus mutates, we're going to see a different pattern appearing, and that, for the modelers and for people who are responding to the pandemic, creates a high degree of uncertainty. So what did we know and what did we not know? We only knew 3 weeks after the first cases that the virus could be transmitted from human to human. We knew it was a respiratory disease, but there was a debate about the modes of transmission that has continued until fairly recently about airborne transmission as opposed to transmission through surfaces. The issue of who was highly vulnerable, there are 2 studies in South Africa that were released in August of last year that clearly showed us who was vulnerable. So for the first 5-6 months, it was unclear who was more highly vulnerable, except we knew that this was a respiratory disease. What we do know now is that males, people who are 60 plus, people with diabetes, hypertension, chronic kidney disease, and TB and HIV are more susceptible, more likely to be severely ill, and more likely to be hospitalized, and more likely to die. So these are the 2 references that gave us from these cohort studies that gave us this bit of information. There were lots of debates about the interventions. As you know, in the UK, for example, there was a lot of discussion about letting the virus burn itself out as many people get infected. There was a lot of discussion about the impact on health facilities. And of course, Mark will tell us about lives versus livelihood, our lives and livelihoods. The impact of the lockdowns and the transmission and the economy continues. There's now increasing discussion again on whether we should shift from national lockdowns or national interventions to more localized interventions, but there are practical difficulties there. So that's still unclear about how deep the intervention should be and how wide. We knew that the viruses mutate, all viruses do, but the uncertainty is when, frequency, transmissibility, and of course, virulence. The limited data, of course, made modeling very tricky. When we did modeling during the second wave, not knowing anything about Delta, the feeling was the third wave will peak at a much lower level than the second wave, but what we've seen contradicts that, of course. So there's a prediction of a fourth wave in November, but we don't know, how high and how long that would last. The need for large volume of testing, but test kits were limited. There was global demand, suspension of air traffic. And the antigen tests, as opposed to the PCR test, took a while to arrive. And specificity and sensitivity was not as great, of course, as the PCR test. And the suggestion was it should only be used when incidence was low. There was a long discussion that we've had about pooled testing to increase the efficiency of the testing. Treatment regimens were not known. We've gotten much better. In fact, our clinicians have done a sterling job, but there are still controversies, as you know, ivermectin being one of them. What to budget for, and I'm sure Mark will go into this, how to protect health workforce, how to mobilize additional staff, and that was a big challenge in the first wave. We didn't have enough nurses and doctors. Funding for oxygen, the oxygen consumption went through the roof, as of course, as you would know, the PPE requirements. The big challenge with responding to this is not knowing when each province will start to move, when they would peak. And we saw that being quite differential in the 3 waves. The first wave, the Western Cape and the Eastern Cape peaked first. But if you look at the third wave, the Western Cape is peaking now. Eastern Cape will probably follow, and we're seeing a significant rise in KZN. So some conclusions very quickly. Unprecedented scale of the impact of the virus, difficult to prepare, and in the context of weak and fragmented health systems. Much was unknown about the virus and, of course, its impact, and we still obviously don't know how the virus would mutate and what the transmissibility and virulence of new viruses are going to be. But I think, we should be proud of some of the responses, and I've put some quotes up here to show that at least in the beginning of the response to the virus, we had fairly decisive leadership from the president and the former Minister of Health. Dr. Tedros, the DG of WHO, said in March 2020, and I quote, "I thank President Cyril Ramaphosa for his leadership and all South Africa's government and all of the society COVID-19 response, with citizens doing their best to adhere to measures taken to contain the coronavirus. However, we know that there's significant fatigue with responding to the coronavirus, especially with respect to the NPIs, and now a significant drop-off in the rate of increase of people getting vaccinated." The Center for Strategic and International Studies said this in May: "South Africa's response to the outbreak has been standout in the region. President Ramaphosa has been an effective communicator, speaking frankly to his constituents about challenges ahead. His government moved to close borders and restrict movement, and now is gradually adjusting alert levels and policies to ease enforcement in specific cities and communities." And I'm sure Slim said this as well in a paper that he published in May 2020 in the New England Journal. He said this, and I quote, "South Africa's early interventions have delayed the COVID-19 peak. In response to being implemented, its response is being implemented in the face of constrained resources and other challenges. The national commitment to responding to the epidemic provides hope that the country won't experience the devastation seen elsewhere." Of course, that has not proved to be particularly true, as South Africa braces for an expected surge of cases over the coming weeks, etc. However, the African Academy of Sciences, Ms. Naika from the African Academy, had this to say in June, that there's been some limitations to the early responses, and these include the Ministerial Advisory Committee being dominated by medical professionals, differences amongst advisors on the lockdown strategy, and the absence of engagement with civil society. Now, the good news is that there's been a Ministerial Advisory Committee that's focusing on behavioral issues and social issues, and there's another one on vaccines. However, the issues around lockdown, how to do it, etc., I'm sure will continue. So my absolute last slide, Chair, would be this slide from Slim, Professor Abdul Karim, and he described it in the New England Journal as, "I described the national COVID-19 response as," and I quote, "sailing a ship while building it." And I think this was true in the first 5 months of the response, and I dare say that for the most part, it will continue to be like this. And I think the truth of the matter is that we will continue to have variants of this virus, and we will have to figure out how to live with it, pretty much like we have learned how to live with the influenza viruses, with its various variants every flu season. Thank you very much for the opportunity. Oh, back over to you, Prof.
Thank you very much. Okay, if you hop out of, thank you so much. That was inspiring, and I think all of us have been, I mean, every country in the world has been sailing and occasionally nearly sinking while building a ship. Ronelle, I'm going to ask you, and then actually, Mark, if you don't mind, I'd like you to follow from Ronelle and allow Musa to go at the end because of the nature of his presentation. So, Ronelle, your 15 minutes starts now. Over to you. I think if you can put that on slideshow, thanks, Ronelle, that would be great.
Yes, I'm doing that now. Can you see it and you can hear me?
We can see it, but it's still in editing mode and not in slideshow mode. So go down the bottom and just put it into ordinary slideshow.
I am putting it in. This is, for me, it's full screen. Is it not full screen on your side?
No, what we're looking at is the editing function, not the full screen.
Okay, I'm not sure exactly what's wrong. Should I try and share again?
Why don't you, very briefly?
Okay.
Well, can I encourage people to be including any questions that you have of Dr. Pillay now, so that we're ready to go as soon as it is question and answer time. And thank you for your attention. Professor Berger, are you ready?
Is this working now?
No, never mind. It's not.
So, Prof, for now, what you can maybe do is just use the book view at the bottom of your screen. It's next to the slideshow full button on the bottom of your screen.
Yes.
Does this work?
Perfect. Go.
That will work. Thank you.
Okay, great. Sorry about that. So with my brief presentation, I want to link to what Jürgen has said, but present the same events from the perspective of an academic and a development economist. As a development economist, I have a vantage point where I focus on well-being, of course, and in particular, the well-being of the poorest. I specialize in health, so that means that I have an interest in how health contributes to well-being, but again, with a focus on the poorest and the most vulnerable individuals. So we know that the experience of the pandemic has been devastating, a devastating life quake. In fact, it has changed lives forever and has increased poverty and inequality globally and in South Africa. I was part of a team of 30 social scientists who has been involved in rapid data generation and analysis via the NITSCRAM project. And through this involvement, I really have had a front row seat in learning more about the pandemic and specifically its health and social impact as things evolved. I will not share today specific findings with you. There are other sessions where you'll have opportunity to hear about the findings from this NITSCRAM work. But my aim today is to take a step back and to share some thoughts and insights about policymaking and policymaking trade-offs during the pandemic. The first point that I want to make today is that the situation that we've seen develop over the past 18 months is quite historic. This is the biggest slump in global economic growth per capita since the 1950s, as you can see here on this graph. It's also been very unique in terms of the width of its economic impact. It's affected most industries in almost all countries, whereas previous recessions have often been more sectoral or more sort of regional. Similarly, the pandemic is the most severe pandemic that we've seen since the Spanish flu of 1918, but even more remarkable, actually, has been the coinciding of these two events, the economic and the health crisis. Since the 1920s, we have not had a coinciding pandemic and economic crisis. And just for interest, I wanted to note here that in the previous pandemic and economic crisis coinciding, the 1920 to 21 recession was due to the aftermath of the First World War, but also part of that was the aftermath of the Spanish flu, which, according to a recent paper by Robert Barrow, generated a decline in GDP and consumption of about 6 to 8%, primarily due to the deaths of the working age population because of the Spanish flu. So it's important to know that this is really quite a unique event and therefore very, very complicated to navigate. And I think Jürgen has touched upon this, and I think that's something that's important for me to share, is that the pandemic manifests in very different ways based on the context. And I think this has been one of the problems of the evidence base for decision making. At the early stages of the pandemic, decisions had to be made, but the only evidence that was available was from contexts that were radically different from ours. A small literature has since emerged around this, and it has pointed to at least 6 ways in which policies and choices about the pandemic are radically different in developing countries compared to developed countries. And on the left, you'll see the summary of these 6 factors. The first one, which I think we're all well acquainted with, is that Because of the lower average age in developing countries and the aging populations in developed countries, overall the mortality risk and the sort of case fatality ratio, it tends to be lower in developing countries. But then also on the sort of the impact side, the impact of sort of mitigation and suppression strategies, the context of developing countries means that the impact is spread quite differently and the impact looks differently if we have a lockdown or if we have social constraints to movement and sort of specifically sort of constraints to working. The first one is the greater informality, which makes it difficult to compensate individuals for income foregone. Then the fiscal constraints, which means the depth and the generosity of what can be provided to cushion the impact is lower. And that also sometimes affects the rate of the recovery, but we know it also will affect individual well-being and impact on the social consequences of any mitigation and suppression responses. Very clear that the ability to continue to work from home and learn from home is very different because lower access to internet and IT, and also the nature of the work is quite different. A lot of the work cannot be done remotely. The fifth point is poor compliance with stay-at-home restrictions, partly due to civil obedience, but also because the cost of staying at home might be very different depending on your living conditions. And then lastly, the depth of savings and the lack of savings, the depth of poverty and the lack of savings really impacts sort of what loss of income means and how it hits a household. And in very impoverished contexts, it often has more severe consequences leading to hunger and impacts on health, which is a concern. But what does it all mean? The graph on the right is an illustration of how these different costs and benefits in developing countries versus developed countries influences the trade-offs and the estimated value of intervention. And what you will see here is on the x-axis the different policy options in terms of mitigation. The first one is to do nothing, and then the responses are increasing to the right in terms of their severity, with early suppression and late suppression being on the very right. This is a graph by Zachary Howell Barnett and Ahmed Mubarak, but you have various versions of this, and they tell approximately the same story. This one specifically, the mitigation measures were defined to be a 45% reduction in interpersonal contact rates and suppression strategies. Interpersonal contact rates, and the suppression strategies involving wide-scale intensive social distancing was defined as a 75% reduction in interpersonal contact. So far more severe the suppression versus mitigation. And what you find is that far lower benefits for low-income countries than there are for upper middle-income countries. And the reason why I think this is interesting and why I wanted to mention this is, of course, because in the early stages of the pandemic, we needed to make decisions, but the only evidence that was available was from contexts that were radically different from us. We had the examples of the UK and the US, but their graphs look very different from ours. And I think we need to remember that. We'll talk later about sort of how to assess the choices that were made and the difficulty of that. This graph, slide, I tried to summarize what we've learned from the pandemic and the research that we've done from NITSCRAM. As I said, I don't show findings, but this is a summary of the different impacts. On the left, you will see the COVID-related losses. We have deaths, hospitalizations, we have long COVID, which we're just beginning to understand, and then also the experience of severe illness. And of course, these all have social and economic impacts that need to be taken into account. But then I think it's also important what we've learned in terms of sort of the wider social and health impact of trying to constrain contagion and how that has played out. Specifically, the very first hard lockdown, we've seen very heavy impact on job and income loss. Associated with that also, of course, loss of on-the-job learning, and then it disrupted production and trade. But the ongoing restrictions on university and school attendance, and even the type of attempts to ensure that schools are safer places, which often meant that there was a rotational attendance at school, which means that there is effectively less school happening. The research has shown that there has been a dramatic impact on loss of learning, equivalent to a year of schooling. So definitely there are large impacts there that will, in the end, importantly, have an indirect impact on health. Also, there's been impacts on health services. You've seen in the papers, and there's been papers to document impact on tuberculosis and HIV screening, child vaccinations, contraception distribution, and of course, all of these will also have downstream impacts that we'll need to manage and that we need to respond to. The media and the NITSCRAM have documented the health and social incomes in terms of hunger, violence, mental health. And then there's also the enduring impact on consumer activity and expectations. Specifically, we worry about demand for tourism, entertainment, restaurants, and then how worries about job security will impact spending and the economy over the long term.
Can you begin to wind up, please?
Sure. The positive side, however, is that there are a space where complementarities exist, and we have alignment between saving lives and working and learning, and that would include strategies such as vaccinations, information campaigns, masks, social distancing, stay at home if you can, avoiding crowds, hand washing, all of the different strategies on the left. And these, of course, as Jogan have illustrated, are things that we learned as we experiment, and the world have been experimenting with different strategies. The crucial link, however, and I think this is maybe the most important point, is that what we've also learned is that enforcement is not feasible. The US research has shown that only 7% of behavior change was via regulations. Most of it is voluntary. We know that vaccinations cannot be compulsory, but also mask wearing and social distancing. What can be policed is very public mask wearing. But the important point here is that private social interactions with close and frequent contact is likely to contribute a large share of COVID contagion cases, and that cannot be policed. So it's very important that there's true and deep behavior change, and that type of behavior change is driven by beliefs. And for that reason, credibility and trust are absolutely vital, and effective communication of information is also vital. Added to this is perceptions of fairness, and what we've learned is that stricter measures come at a higher cost because of the loss of credibility and also the earlier onset of compliance fatigue. I can end there. Thanks.
Thank you very much for that. I'm sorry to have prevented you from, I'm very worried about time and maximising interactions, Renelle, so forgive me. The next speaker is not as originally scheduled, but the next speaker will be Mark Blecker. And Dr. Blecker, over to you.
Okay, thanks very much.
I'm strict about the time, right?
Good. Let me start my alarm clock then. Good morning, everybody. It's good to see so many people here. Hope you're all well today. Veronica's going to put the presentation up for me. I've got quite a lot of slides. I'm not going to talk to all the content of the slides. I'm going to pick out 1 or 2 interesting points per slide. I've got about 20 slides here. Okay, can go, Veronica. All right, so talking about lives and livelihoods, going forward from the previous 2 presentations. Next one, Veronica. Okay, won't go through all the points here, but I think one of the issues about the very strict lockdown we had initially, the phase 5 lockdown and the phase 4 lockdown, was perhaps a little bit of uncertainty about what the objective of that lockdown was. Was it an elimination? Was the objective to eliminate the virus? Was it to contain the virus, mitigate the virus, to flatten the curve? What exactly was the objective? But after a couple of months, of quite a strict lockdown, the president said that the response is increasingly framed as a marathon rather than a sprint, trying to seek some kind of balance between protecting lives and livelihoods. And just a quick advertisement that some of the stuff that we're presenting today will come out in the forthcoming South African Health Review. We've got a chapter there on lives and livelihoods. That's the book that Health Systems Trust puts out. Okay, next slide, please, Veronica. So, Jürgen's already showed the 3 waves. So I won't repeat those here. Most of you are familiar with the different waves. The mortality waves being slightly below the second wave, the third wave. Hopefully that's because of some of the protection from vaccines, amongst others. Okay, next slide, please. And most of you are familiar with the stats on the live side. The Department of Health puts them out every day, but not all of you will know that the excess deaths, which the Medical Research Council puts out, is about 229,000 deaths compared to 77,000 that the Department of Health presents. So it's about 3 times as much. And also, if you look at the slide that was presented on COVID by Renette, she showed, I think, globally 4 million deaths. So again, if you look at excess deaths globally, it's closer to probably 40 million as compared to 4 million. So much bigger, much more comparable to that 2018 flu. Okay, next slide, please. So this is kind of an interesting slide on what is called the Stringency Index. And South Africa is the red line, and you can see us as the president declares that level 5 lockdown, going into a very high stringency index, lasting for quite a lot of months, going into then the level 4 lockdown. And the curve below that, the bluish one, is the global average stringency index. So you see that South Africa's stringency was more stringent than the whole world for quite a long time, actually. And even now is actually above the global stringency index. All right, next slide. Thank you. And so coming on to livelihoods, there was very little understanding of the livelihoods initially with the lockdown. I think people didn't really think about this initially. And suddenly food queues started growing. And some of you will remember, you would see these queues of 5 kilometers long of people standing around waiting for food. And millions of informal sector workers not having savings and not then having jobs. So if you were in the formal sector, you could perhaps get some relief. And this is the point that Renette makes, that in Africa and in informal economies, you don't have the social security that you have in developed countries. And at that early stage, it was really, everyone was just talking about lives. At that point, no one was talking about livelihoods, and it was difficult to even open up discussions about safe reopening of businesses. People at that stage weren't thinking that you didn't need to close the shop. You could rather just, social distance in the shop. People didn't think about that at that time. And then people started to think about, well, we have to do some social relief measures, but there still wasn't much understanding that businesses were closing and jobs were being lost. And it was only in when I think when the first adjustment budget came out in June, and it showed massive effects on the fiscus and on job losses. And the first NIDSCRAM survey and the first quarterly labor force survey showed 2.4 million jobs losses, that people started to actually realize this thing's got a really, really serious effect on businesses and on the economy. And by December, WHO was also starting to give guidance that countries had to consider lives and livelihoods, and the conditions in developing countries were different. And also there was very limited quantitative planning tools that could bring together the epi models and the economic models. And we've been in some kind of lockdown for 16 months, now in level 3, and we saw mass looting in KwaZulu-Natal and Gauteng in July, partly linked to prolonged losses of income. And we see widening, deepening of many poverty indicators. Next slide, please. I'm not going to go through the detail of this, but basically about 21.5 billion was either reprioritized or allocated in the health sector to COVID in the 2020 year. Okay, next slide, please. This is just for the vaccine rollout. So those numbers are very small, so I can actually hardly read them from here. But we've allocated about 8 billion in this financial year to vaccines to the national department, and about 1.5 billion this year to the provinces to implement the programs. And there's still some additional funds in the contingency reserve. We just allocated, Minister just signed off on another 2.4 billion, taking that up to 8, because the initial allocation was about 4.3 billion. And the country's ordered 73 million vaccine doses and 5 million donations. It's 78 million doses. We've only used 9.4 million of those doses so far. Okay, next slide, please. Veronica, next slide, please. Is my presentation frozen,
No,
Veronica?
It hasn't moved. Can you just keep talking and I'll try and get her. She doesn't seem to be on. I'm not sure what's happened. Can you keep talking, Mark?
All right, let me just open it on my side then. Just tell me when it's back.
No, it's back.
So it's back, okay. All right, so the economic impact was really massive. I mean, that second 20 was a 16.6% quarterly reduction. It ended up being a 7% annual reduction, which is, as Renette pointed out, I mean, the biggest reduction in 70 years. Initially, a loss of 2.2 million jobs, 1.4 million jobs down. Government revenue dropping massively, about 125 billion a year, with projections initially that it might be as high as 300 billion. Is it stuck again, Veronica, or can you change?
We didn't hear you. Veronica, please change the slide. Mark, you've got about 4 minutes, and the slide is correct.
All right, so shows the tax on the table at the bottom. The tax collection was revised down by about 130 billion a year. And so this effect on the economy and fed through again to government spending, and it ended up affecting health department spending from the 21 year and social grant spending and all other government departments spending. So this is the effect of the epidemic and the lockdown on the economy effects. Okay, next slide, please. And this shows the effects of the funding of line growing very strongly in the middle is government debt. So government debt grows by about 100 billion debt payments a year, while tax revenue is declining by because my time is education line, the health line, and the social grant line there. But you see all of them declining from 21 as the effect, the livelihood effects of this pandemic and the lockdown feed through. Next slide, please. And budget 21, perhaps being the most difficult budget in a century, the largest economic drop. We start entering into a debt crisis. Interest on debt starts exceeding 20% new. These big cuts in spending across many departments. And meanwhile, OECD, the World Bank, don't discontinue stimulus too early, warning against the effects of austerity on health. Meanwhile, we're in significant debt. The fiscus is being kind of restrained back, and South Africa then enters the third wave with these cuts in expenditure. Next slide, please. And one looks at various forms of livelihood protection. This one is the TERS protection through labor, paying out 59 billion to furloughed workers. Next slide, please. And this is in social grants, social development, developing 2 new social grants, the 350 grant, the caregivers grant, and all the other grants being topped up. Because I haven't got time, I can't go through all the details of these. Next slide, please. This is just an example of an early costing exercise, how the increases in these grants would cost 40 billion in their first 6 months. And of course, the SRD was then extended twice, and a new reintroduction for 8 months this year in the third wave, and after what happened in KZN and Gauteng. Next slide, please. And so just one or two concluding slides. So it's kind of hindsight is easier than foresight, and early lockdowns, strict lockdowns for a long period may have saved lives and helped to delay. But these complete lockdowns proved to be an extremely blunt tool with vast economic and socio-economic effects. And the less stringent lockdowns in the second and third wave mean that they've had economic implications. And we're still sitting 1.4 million jobs down, tax revenue down, serious reductions in health and social spending coming out of this, which is going to require continual review. And this, from a methodological point of view, also emphasizes the need for academic decision-making and modeling, quantitative modeling and policy making to consider lives and livelihoods. Last slide, please. We have to consider what happens to the 350 grant next year. There are discussions about BIG, the 350 SRD grant, public works programs, the Brazilian Bolsa Familia program, or maybe we can't afford any of those. Maybe just to end, because my time is up and Lenora is appearing on the screen, to say that inadequate early attention to livelihoods, especially jobs, will leave long-standing economic and livelihood damage. Thank you, everybody.
Thank you very much for that. Thank you, all three of you. Musa, I'm going to give the microphone and video to you immediately. You have 15 minutes. Your time starts now.
Thank you very much, Lenore. Greetings, fellow panelists and attendees. Much appreciate the opportunity to share. I'm going to try and share my perspective on this issue of uncertainty on lives and livelihoods from a personal journey perspective. And it's got to do with the fact that from early on, we recognize that whatever is going to happen with the pandemic and whatever decisions are going to be made, these were going to affect people directly. And there was a need for every sector of society to start to move. And, we had learned from HIV that, the civil society plays an important role. We had learned from NGOs, the academic sector. And for us, it was a question of, from where we stand, what is it that's going to be our role, and what are those decisions and actions going to be informed by? So my own journey starts from the point where we set up the COVID-19 war room at the University of KwaZulu-Natal. And this war room, we set it up in February before we had the first case in South Africa. And people kept asking us, why is it that we acted early? And I remember doing an interview with a radio station when we launched it on the 3rd of March. And I was asked a question: are you sure you are not overreacting to the situation? And at the time, I said, look, we may be overreacting, but given the trend in the world, it's better to be prepared and act early rather than wait. And in early February, I had come back from a situation where we had visited Singapore. And in Singapore, I was attending a meeting not related to COVID-19. And they only had 12 cases. And they were one of the first few countries where, the spread had, cases had spread to. They had imported cases at the time. And it was when we were there that they introduced us to their approach to COVID-19, which they had basically developed when they had the SARS epidemic. And there were so many lessons to learn from Singapore that even when we were on the day that we were leaving, they had their first case of community transmission or local transmission. And we watched live the way that they started to escalate their alert level and basically get people to start working from home. And when I got back, I basically started to develop a COVID-19 response team and model based on the Singapore experience. And the later on in South Africa, when we went to the risk-adjusted strategy of 5 levels, we had drawn those lessons from the 4 levels that were there in Singapore. And we were saying to everyone that let's learn from countries that have experienced this before, given that we hadn't experienced this. And it is that issue of thinking ahead of time before you are faced with the scenario on what is it that you're going to do in the case of a scenario where there's so much uncertainty. And that was really the challenge and the question that we were asking. When we set up the war room, we set it up ahead of time in order to prepare ourselves. And we developed the pillars, the 3 pillars that we needed of prevention, of surveillance, and also of treatment based on that model. But I want to get into the specific thematic areas of some of the key lessons that we had learned. Having to navigate the scientific unknown is very difficult, especially in a policy environment where rights are so important in South Africa, and there's so much demand from the public, from the media for accountability. And you have to make sure that you make evidence-based decision all the time. If you can't defend your decisions, you will be taken to court and they are going to be tested. And so, especially when they've got major implications for society and for a lot of people. Now, it's difficult to make those decisions when you've got very little information. And so we had to get into the habit of making the decisions with the best evidence available, not necessarily the right evidence or the evidence that is right. We didn't really have that, but it did not mean that we could not make decisions. We had to actually make those decisions. And also we saw that with the lockdown. And I think that Jürgen mentioned the modeling team that was put together to make projections, to, guesstimates of what might happen and make decisions based on that. And we saw later on how those teams were criticized because there was a gap in the projections that they made. However, those criticism did not necessarily take into account the early action that colleagues have referred to. And the early action is the one that basically potentially helped us to reduce the gap between what was projected and what actually happened. And so when that happens, I call it, we become the victims of our own success. You do something that's good for you because you're acting on the basis of the best evidence available to you, and you prevent a potential disaster. And people then come out who are going to criticize and say, well, you overreacted, you overestimated, this was not going to happen anyway, not accounting for the actual decision that happened in the background to help prevent a disaster. And we have seen this to a small extent with HIV, but we saw it on steroids when it came to COVID-19. And this is where, for me, I had a challenge with our natural tendency to wait for evidence to be concrete before we make a decision. And we saw this many times. And as a result, even our policy processes were seen as reactive rather than proactive. But it is this sort of margin of uncertainty that really pushes us towards this reactive approach where we wait for evidence to be concrete before we act. The other thing we saw was this importance of balancing the health and economy. Initially, it was that tension that we debated a lot about. It was almost as if those of us in public health were at odds with people who had an economic interest in the country. And when with the first lockdown, we then realized the impact it had, and Mark refers to this, on daily lives. And that's when we introduced a social component to it. And that's when we started talking a lot about the social compact. I mean, the surveys that we did with the HSRC to try to understand the impact of the lockdown on everyday lives was really instrumental in helping us begin to shape this thinking. And so the combination of the broad economic issues and macroeconomic issues to the impact that it has on everyday lives and jobs for people, then it started to evolve into this argument of livelihoods, combining the impact between the two. And when we started to look at it that way, it started to reduce the tension between what was of public health interest and what was of interest to individual and the livelihoods. And so that convergence for us was really important because then it made us come to terms with the reality of the need to balance the scale across different sectors, across different areas of interest and priority. And the risk-adjusted strategy, as was also kind of captured by Ronel, began to do that. And that's when we realized that, you know what, yes, it's a pandemic, but it doesn't mean that all the decisions have to be based purely on public health priorities or public health indicators only. So this balancing act, the risk-adjusted strategy was trying to bring those different things together. And it was better articulated at that point. And for many of us, we came to terms with it. And we realized that we can put the evidence forward that we are aware of, that we currently have. But then the decisions then, from a policy perspective, have to be weighed with other things. Now, I just want to highlight this issue of the margin of error, the criticism that comes. And when there is so much criticism, it pushes us to innovate. The issue of excess debts and what the SMRC started doing in producing data on excess debts came because of a lot of criticism around how we were capturing the debts. And Mark has demonstrated that you can have numbers of 77,000, but actually true numbers in society might be over 200,000. And we needed to be able to have different ways of measuring the impact of the pandemic and begin to bring these different sources of evidence together so that we can look at consistency across different pieces of evidence, even if that evidence is limited, but it helps us in affirming the decisions that we then have to make. So that, for me, was an important milestone in helping us to reduce the unknowns around how we were monitoring the deaths. Now, the next thing is this issue of the proof is in the pudding. At the end of the day, we can come up with all these policy decisions. They're all going to be tested when we put them in the real environment. And a good example for me has been around this issue of vaccines. When you look at the fact that we talked a lot about vaccines being effective, and then side effects and so forth. And when we put the vaccines on the ground, we put them at the same time that we were having the third wave. And of course, people who are getting vaccines are also going to have COVID-19 before they develop the immunity. But people who are not, society, the public was not prepared for that. And then we ended up having situations where people were dying, many of them from COVID-19. But because the evidence was not there available to them, they made an association that the relationship between the vaccine was causal with the deaths that were happening. And trying to manage that is very difficult. It still is, but we've been trying to sort of publicly mitigate against it, but it's very difficult. And it requires a lot of transparency, a lot of advocacy, and a lot of activism in order to curb that perspective. But all of it, I saw it as a shift from the concerns around vaccines in terms of myths to the concerns around vaccines in terms of their lived experiences, what people were actually experiencing as they take vaccines. And a lot of people did not see that shift, even in terms of the concerns around vaccines. But then for policymakers, when we are managing uncertainty, it becomes difficult for us to detect those changes in the tempo of the concerns that exist so that we can mitigate. The last thing that I just want to mention has a lot to do with the fact that whenever there is a lot of uncertainty, we see the rise of the forces that begin to exploit that gap, that exploit the unknowns that we have. A lot of the times, the attitude that we take, especially from policy perspective, is to ignore it, hope that it will die down, and hope that the decisions that we make will actually mitigate against it. The problem is that under normal times, in peacetime, that might be true. But in the middle of a public health crisis, that sets us back a lot. And we are seeing it with the vaccines now. We saw it with other things. If we are not going to actually see it as an issue and mitigate actively against it, then we are going to be set back. You know, it's almost as if you have to all of a sudden develop a strategy to counter misinformation, to counter disinformation campaigns. And when you look closely at those campaigns, a lot of the things that is frustrating is they're not just driven by pure health concerns, medical concerns. The medical concerns and health concerns and the gaps in knowledge are driven by economic concerns, people who are concerned about their businesses and unhappy about the policies that are being made because they're losing income. They're driven by people who are trying to dominate the market in terms of companies and countries that want their vaccines to be used in the market. They're dominated by political agendas that basically have in the context of campaigns that are there. When we have these conversations, we start to realize how complex it is. And now we in public health have to formulate messages, but these messages cannot be formulated purely from a public health perspective. They have to really be considered from different perspectives. So let me wrap up because Lenore wants us to get into our conversation. But just to say to you that, yes, it's important to look at the dashboard. Yes, it's important to look at the indicators, but let's also turn around and look at the lived experiences of people, anticipate before things happen. And when they do have their lived experiences, let's draw out from their actual experiences and speak to them according to their daily experiences. And that, for me, is going to be the challenge for policymaking going forward as we manage and navigate this uncertainty. Thank you very much, Leno and colleagues.
Thank you. That's really wonderful. I really appreciate it. All of them. I have a number of questions and more will come through. I'd like to begin, though, by taking three that I think, Dr. Pillay, you would be well positioned to answer. I'm going to give you all three together. Firstly, would not early testing have reduced hospitalization? Secondly, is there any evidence, these are all sort of epidemiologic type questions, is there any evidence of a drop in infection since immunization began? And thirdly, how do you predict peaks for each wave across provinces? Okay, so the first one is about early testing and its impact. The second one is about the impact or not of immunization thus far. The third one is about predicting across provinces.
Great, thanks very much, and also thanks to my fellow panelists for their inputs. And thanks very much for these three questions. So on early testing, well, I think one thing we need to remember is that a large percentage of people are asymptomatic. So people with no symptoms have no reason to go and get tested. The second is that people often think that their symptoms are mild, it'll go away, or it's flu-like, and don't go and test. So there are quite a few reasons why people either don't test or delay testing. But what is true is that if you test early enough, you will have a diagnosis and then you will know what to do about it. But the key thing about a diagnosis and symptoms is as your symptoms get more severe is when you should be consulting a doctor. And of course, the doctor will then say whether or not you need to be admitted. And the key is having problems breathing. The minute you have problems breathing, you should be concerned and seek medical advice. In the early part of the pandemic, as I said in the presentation, one of the challenges was we didn't have enough tests. Now we do, and they have become somewhat cheaper. They're not cheap, but they have become cheaper. And we have these antigen tests, which will give you results in 15 minutes, as opposed to the PCR test, which is a more laboratory-based test, which takes 24, 48 hours to get a result. In terms of drop in infections with vaccines, the vaccines don't prevent infection. What they do prevent is serious disease and hospitalization. And I think we need to understand the role of vaccines in this context and the limitation of the vaccines that we currently have. So as Musa said, the number of people who think vaccines don't work because after vaccination, they have symptoms of COVID and are diagnosed as COVID positive. So the vaccines don't prevent infection, but they do prevent serious disease, and they limit the number of people who are admitted with serious illness. In terms of prediction of the next waves, we've been working, and I've been working with the modelers from March, as I said, to use the best evidence we have. And the inputs into the model are varied. You would look at, now that we've got some evidence of previous waves, you will look at previous waves, you will look at levels of immunity that the previous waves have resulted in. You will look at vaccination coverage now, which you look at mobility. What we do know is that the virus moves when people move. And that's one of the reasons why these lockdowns were put in place, to stop people from moving, either from within cities or between cities and between provinces, etc. It's been quite difficult to predict. As I said in my presentation, if you look at the first wave, the coastal provinces peaked before the inland provinces. And in the first and in the second wave, the so-called rural provinces, the inland provinces, had significantly lower rates of infection. But if you look at the Free State, Northwest, Northern Cape right now, they've been in a prolonged second wave. In fact, there's a lot of debate about whether the Free State and Northern Cape even moved out of the second wave into a third wave, or they've continued through the second wave, at a high level of rate of infection. So, these are the kinds of inputs that have gone into the model, and that's what's being used to kind of think about when our next peak will be. And the current estimate is that it will be around November. We are hoping that the number of serious illnesses and the numbers of hospitalizations will go down as vaccination coverage increases. And that's what we would need to do quite rapidly. At the moment, fully vaccinated over 18 stand at about 10%. We need to grow that to at least 60-70% by the end of this calendar year. Thanks very much. Over.
Thank you. The next questions I'd like to ask to Professor Berger, if I can. The first one I want to ask, which is from a research consultant from Urban Economics, is, will COVID change the way we work indefinitely? Is working from home the new normal? And that, of course, is a question that's an interesting one specifically for South Africa. And then the second, and relating to the structure of the workforce. And then the second question for you that I'd like to put is, what is your take on mandatory vaccinations?
Thank you. In terms of the first one, I think the important aspect to remember when we're talking about working from home is that for the very thin layer of jobs where it is possible to work from home, I think it is very likely that that might start becoming the rule or the trend, because there's now far larger sort of social acceptance. People know the tools, and also the benefits of not losing travel time, not flying to Johannesburg, but also I think a lot of the companies have seen massive savings in terms of electricity, heating, all kinds of factors associated with lower use of the offices. And of course, over the long term, they might actually be able to do away with some of those offices. So yeah, maybe for those who can. But I think the important thing really to remember is in South Africa, very, very small share of individuals can work, can do their job from their home. And I think that is what partly makes it so very problematic to navigate the epidemic, the pandemic. In terms of mandatory vaccinations, we have done some work on vaccinations, which I have not presented here. You've seen in the US that certain employers have made vaccinations mandatory. I know that for health workers in the US, and also I saw that Disney made vaccinations mandatory. I think that is a legal question. I don't think it's legally okay to make it mandatory to everyone. There might be certain professional context or economic context where it might be defensible to make it mandatory. But I really do hope that that's not a solution for everyone. So I really do hope that we will make progress with vaccine hesitancy, and not only vaccine hesitancy, but I think providing ways to make vaccinations more convenient in that way, and also expand sort of access, and in that way make sure that we have higher vaccinations, especially amongst the uninsured, where we at the moment having trouble making headway. Thanks.
Excellent. Thank you. Dr. Blecker, I've got two questions I'd really like to ask you. And the first one I'm going to paraphrase slightly, which is, given what we know about the South African labour market and social grants before the lockdown, why were we surprised that COVID exacerbated inequality, and why do we talk as if we had little understanding of livelihoods? So that's the first one, which I think is a really interesting one to reflect on. And then the second question, which is a fairly extensive one, is again around the connections of health and social justice, which you raised, but also in light of food riots and therefore food insecurity and other securities and so on. And so the question is around immediate and short-term versus longer-term responses, and questions around health system strengthening as essential in order to ensure ongoing social protection. So I think both of those questions are around structures and the relationship between the economy, between the role of the state, and what was both revealed and the impact of the pandemic on individual livelihoods.
Thanks. I didn't get the second question fully, but let me try, and you can perhaps just prompt me if I haven't got the question clearly. So on the first question, I mean, for me, there's two aspects. So my sense is that most of the major decisions in the first 3 months of the epidemic were really just focused on on lives. They just didn't really think about livelihoods, didn't anticipate livelihoods, and didn't really want to talk about effects on the economy and what that effects on the economy meant for employees or informal workers and so on. There was just a kind of complete focus on the lives part of it, and particularly the escalating mortality. When kind of within, say, the first 2 or 3 weeks, people started realizing, look, you couldn't have these growing food queues and no kind of income protection response. Yes, a 40 billion social assistance response was put in place, and I mean that was put in place fairly quickly. I mean it could have been maybe 2 weeks earlier, but the epidemic started in March, and I think say about the 20th of March, I think the first grants started from the 1st of May. So yes, an assistance response was put in, but I think the message that the effects on livelihoods went much deeper than social grants and TERS took a lot longer to sink in. And the fact that once you get thousands of businesses closing and 2 million people unemployed, that those things are not easy things to reverse. I think that took much longer to set in. So I think for me, that is one of the key lessons of the pandemic, and why this session I think is also interesting on lives and livelihoods, because I think both from a kind of technical modeling point of view, but even from an early policy decision, I think people didn't think about livelihoods from the beginning. That's the first question. On the second question, so I mean, I think a lot of problems emerged around food parcels and food, as you say, around food riots. I think social development struggled a lot. I mean, I think that the provincial social development departments and many NGOs did, incredible work on food parcels. But I mean, the sector struggled a lot with it. There was problems around criminality to some extent, hijacking of food parcels, and that's partly also why there was a shift from food parcels into cash. Health system strengthening is obviously quite a critical lesson, and I mean, I'm surprised in a way that Jürgen didn't emphasize more the huge disruptions to basic health services. I mean, huge disruption to HIV services, TB services. There are massive backlogs in basic health services. And even the role of primary care has kind of, evolved, with the epidemic. So there clearly are a lot of lessons on strengthening. But if I haven't completely got that second question, please come back to me. Thank you.
There was a little bit of an extension in that question, Mark, which was around or a medium-term fiscal and social development strategies versus short-term strategies, and how governments, I understood it as a policy question too, including how government was able to balance longer-term strategies when it's faced with immediate expenditure, as has been required in the various social responses for COVID.
Well, I think that's been a massive challenge for us, and I'm not sure that we've done particularly well I think we did well in the first wave, in the first instance, which was the short term, the emergency. So when COVID broke out in March 2020, the president wanted to put in place a 10% of GDP intervention. We eventually got a 6% of GDP intervention, and it was a massive intervention. I mean, it was over 100 billion in income protection and 20 billion in health. But in a sense that, for various reasons, that couldn't be sustained. So it couldn't be sustained partly fiscally because of the economic kind of deterioration that I described, the fiscal, the tax. And so what you saw coming through in Budget 2021 is one of the perhaps most difficult budgets, I mean, we've seen in many, many decades with, large cuts across many sectors. So, I think that in a sense, the medium, even though, for example, in health, I mean, 9 billion was allocated to COVID through the provincial equitable share in budget 2021 and 9 billion to vaccines. But the health sector was cut by 20 billion overall because of the overall fiscal deterioration. So, I think that there are many challenges about the medium term. I think that the short-term response was large and it was very active. The medium-term response has been extremely constrained. Maybe I should leave it there, but if there are more questions on it, I can go more into it.
Okay, thank you. Musa, there's not a particular question at present directed to you, but I actually want to ask you a question, and it is around livelihoods to some extent, but it's also about saving lives and quality of life and what lives are worth and where the investment goes and so on. We've been talking a bit today, as is often the case, about the 19 flu epidemic, and very little about HIV. And we still live with the real pandemic that has affected South Africa in recent years. And I wonder whether you have anything to say about what lessons we might have learnt from HIV, or what lessons we might now begin to look for then and the 40 years of living with one virus that has not gone away.
Yeah, thank you for that question. I think the importance of the question for me starts with the point that Mark made to say that there's been a lot of disruption to services around HIV that we need to pay attention to, and other services really. But in answering your question, from the HIV pandemic, we know that we got to a point where we overcame. And I remember it was in one of the AIDS South African AIDS conferences, and I think Jürgen you were on the panel in that conference. And one of the questions, the session was organized by the health systems group, including Helen Schneider and others. And one of the questions that was asked there was, the main question that was being asked was, how did we manage to overcome HIV? That was the main question that was being addressed in that session. And on the whole, the consensus was that it took a lot. It took all the different sectors involved to overcome HIV. It actually took a lot of activism from people with HIV to overcome HIV. And for me, I think that we are so focused on treating COVID-19 as a new disease for which we don't have tools, which to a large extent is true. But we miss an opportunity, and we miss opportunities to draw from the tools that we have that work for us in our context. And even with the vaccines, for example, if you look at the provinces that are ahead, Limpopo province, Eastern Cape province, they use community tools, traditional leadership, religious leadership, community health workers, community groups. That's what they're using. They said very clearly that they need to move out of healthcare facilities. So there is just no way that we did not learn these lessons from HIV. We knew that to overcome HIV, it took so many other sectors and everyone getting involved and all hands on deck. But I feel like once again, we are trying to run the management of COVID-19 as if it's largely a health sector issue, when actually it covers so many other sectors. And as a result, we leave other players on the sidelines. Even with vaccination, we saw how much improvement came with the bringing on board of the private sector. Yes, we didn't have a lot of experience with private sector involvement with HIV, but they did get involved, especially in terms of philanthropies. A lot of people got involved to help us overcome HIV. I also want to refer to one point about the flu pandemic. One of the reasons why we thought that the third wave was going to be better was because we were looking at the trends of the flu pandemic, where the third wave was slightly better. And it had a lot to do with what we thought was the buildup of immunity and so forth. But of course, the times were different and the trends were different. The issue is that one thing we have to look at from, I suppose, from an economic point of view is that if we go back to look at the subsequent things that happened after the flu pandemic, including the wars and the collapse of economies and the need to start from scratch, it's not something that is completely strange in our environment. And I would like to suggest that we draw from lessons like we are seeing with the unrest in KZN and in Gauteng, that if we are not careful, and we are seeing this around the world, even if you look at Afghanistan, if we are not careful, as a world and as a country and as a continent, we might find ourselves not necessarily adequately anticipating the sort of economic collapse and strain that might happen in the way that it affects individuals every day. That might happen with the burden imposed by this pandemic, especially because the pandemic might last long, especially on the African continent with the vaccine inequities. And the issue of inequity is a lesson, a big lesson that we learned from HIV. In 1995, the US had triple therapy. In 2003-4, that's when we were starting to roll out triple therapy for HIV, 10 years later in South Africa. We are doing the same with vaccines. And in the process, we are putting so much strain on our context, on our economy, on our livelihoods in Africa especially. And we have to really think about that, think ahead, and use foresight a lot more and not depend so much on hindsight, even though it's risky, even though, you know, people might not necessarily fall behind it until such time the late adopters. But I do want to say that, you know, we've learned so many lessons from HIV and from the flu pandemic that we have to draw on and start talking about those things in mitigating the challenges we are facing today. Thank you.
Thank you. I mean, I suppose following from that, I mean, the thing that strikes me is not that we won against HIV, but we have spent 40 years learning to live with HIV and to minimize its impact, particularly on poor people. And what we're talking about today is how do we deal with people, particularly those whose livelihoods are threatened and who are excluded or marginalized, and in an impossibly short period of time. And clearly this is not going to go away in a hurry. So the kinds of things we're talking about now, including pharmaceutical interventions and social interventions and economic interventions are critical. And the more we talk about them, perhaps, you know, the clearer it will become. I want to just make a couple of announcements. And the first is this, one of the highlights of the winter school have been the student debates, and they are intended to encourage participation and learning. There is a debate session on Thursday from 1400 to 1600 with Professor Michael Sachs as the judge and with prizes of the performing teams. There are also 2 more prizes to keep you tuned into Zoomland. One is for the student who is most active on Twitter. My personal view is the more active you are on Twitter, the less you're listening to the discussion on Zoom. But leaving that aside, tweet away. And one for the student who attends the most sessions. And so I encourage you to be attending and tweeting and listening and engaging. I'd like to thank very much Professor Berger, Professor Moshibela, Dr. Blecker and Dr. Pillay for your wisdom and generosity in giving us your time and the thought you've given for your presentations of what has been a really stimulating discussion. I apologise to a few of you whose questions came in a bit late for me to pick up and ping to one of the speakers, and I hope you'll have a chance to talk about those issues yourselves. My task now is to hand over. And so, first of all, if I've got a different screen up, I hope you are clapping for the 4 speakers, because they have been really wonderful and it's been fantastic to listen to them. What I'd like to do now then is to introduce Dr. Reza Daniels, who will be taking over from me as the facilitator for the next session. Dr. Reza Che Daniels is Associate Professor of Economics at University of Cape Town, and before working in academia, he ran his own consultancy company, and he has worked with trade unions, the public sector, the private sector, and with civil society. So he brings a very broad range of experience and interest in activities and initiatives across multiple sectors. Dr. Reza currently sits on numerous advisory boards and has consulting positions, including with government in our country, in South Africa, and with the Asian Development Bank and the World Bank. He has founded or run private companies in the not-for-profit sector and in manufacturing and consultancy. So without further ado, I'd like to hand over to him. And again, Musa, Ronel, Jurgen and Mark, thank you so much.